Welcome to everyone. I mean, the audience is really international. We have a lot of people from all over the world. Welcome to everybody. Today, I have a great personal pleasure to host Professor Paolo Angeli. Paolo Angeli is not only a good friend of mine and an esteemed colleague. He created, actually took over and extended and expanded the liver tradition of Padova, starting from Realdi a few years ago. But I mean, under his wise supervision, the Padova is now one of the leading centers of liver disease and liver pathology in Europe. On top of that, the time of Paolo is also full due to the fact that he is now the editor-in-chief of Journal of Hepatology, one of the most successful journal in the field, second only to gastroenterology, but actually competing with the gastroenterology. And so this makes Paolo not only a very excellent scientist, but also an absolutely outstanding member of the scientific community. Paolo, in spite of his busy time, accepted our invitation, and today he will present the yellow webinar title of New Developments in the Pathophysiology, Classification, and Management of Decompensated Cirrhosis. Paolo, the floor is yours.
Thank you very much, Claudio. It is a big pleasure, personal pleasure and honor to be here with you today. And this is the title of my lecture. These are my disclosure, and this is my agenda. First, I will speak about new achievement in the pathophysiology of decompensation and development of organ failure in patients with cirrhosis. Then I will speak about the new classification and some new achievements in the management of decompensation of cirrhosis. But let me move from pathophysiology. Because for more than 30 years, we went on thinking that the only driver of decompensation and further decompensation was a progressive increase in portal pressure, a related progressive derangement in the cardiovascular function, and the progressive activation of the endogenous vasoconstrictor factors. This is true for sure, but this is only part of the truth. Why I stated this? First, because you can see that in the most advanced phases of the liver disease, there is no further progressive increase of the rate of activation of vasoconstrictor and sodium retaining factors. Second, because we are able to modulate the rate of activation of these systems. So, for example, the plasma renin activity, the plasma concentration of aldosterone by means of albumin and myoglobin, for example, without obtaining by this any result on the clinical ground. No reduction of the rate of complication, no improvement of survival. Third, more important, because during the last 10 years, we learned that another syndrome may develop at any stage of the liver disease, but particularly in decompensated cirrhosis. I'm referring to acute on chronic liver failure that is characterized by the diagnosis of cirrhosis, the development of acute decompensation, the development of organ failure, and the very high short-term mortality, 28-day mortality higher than 50%. Now, a patient may develop ACLF, may develop organ failure, even in presence of normal values of vasoconstrictor and sodium retaining factors, such as plasma renin concentration, but never in absence of systemic inflammation. So systemic inflammation may be a driver of the development of organ failure in patients with decompensated cirrhosis. But you know, systemic inflammation is not only present in patients who develops organ failure, it is already present in patients with acute decompensation. What is it? It is the abrupt onset of one among the major complications of the liver disease, ascites, gastrointestinal bleeding, bacterial infection, hepatic encephalopathy, and in most of the cases, by the sudden onset of more than one among these major complications. But let me say that systemic inflammation is still present even in patients with grade 1 ascites. That I want to remind you is ascites that can be detected only by ultrasonography. And then the level of systemic inflammation will increase in patients with grade 2, grade 3 ascites, and overall in patients with difficult to treat ascites, so that patients with recurrent ascites and patients with refractory ascites. So systemic inflammation is a driver that acts very, very early in the pathophysiology of decompensation. But let me go on. Speaking about another potential driver, I mean oxidative stress. This is the molecule of albumin, and there's you all know in position 34 there is a residue of cysteine that is capable to bind ROS, reactive oxidant species. But in doing so, albumin is oxidized, either in a reversible form, human non-mercaptoalbumin 1, or unreversible form, human non-mercaptoalbumin 2. And you can see that the sum of oxidized albumin is increasing progressively along the course of the liver disease. So a third potential driver of decompensation is oxidative stress. So the problem becomes how to put together progressive increase in portal pressure, systemic inflammation, and oxidative stress. Of course, in a new pathophysiological hypothesis, according to which nowadays we think that the main consequence of portal hypertension and liver failure is bacterial translocation, which is thought to be the major cause of systemic inflammation and oxidative stress, which is the cause of the cardiovascular dysfunction and of the reduction of the effective circulating volume. There are no other mechanisms by which liver failure, portal hypertension can induce the cardiovascular dysfunction. And then systemic inflammation of oxidative stress, together with the activation of endogenous vasoconstrictor and sodium retaining factor, will cause the onset of ascites. But let me say that systemic inflammation and oxidative stress generate a vicious cycle by which there is a further increase in the degree of portal hypertension, further increase in the degree of liver failure, so a further increase in the rate of bacterial translocation, and at the end, a further increase in the severity of the systemic inflammation and oxidative stress. So at any times along the course of liver disease, organ failure may develop spontaneously or for the intervention of precipitating factor at the level of the liver or at extrahepatic level. So, which is the mechanism by which systemic inflammation and oxidative stress can generate organ dysfunction or failure? you can see that systemic inflammation may induce an increase of lipolysis, glycolysis, and proteolysis. But all these substrates will be shifted toward the immune system. So all these substrates are not available for the cell in the peripheral organ. In addition, in the cell of the peripheral organ, there is a reduced availability of other energy substrate because the production of ketone body is reduced in relation to liver failure. And in addition, there is also a mitochondrial dysfunction. So the cell of the peripheral organ suffered from an impaired supply of energy and suffered from a great incapacity to produce energy by themselves. So in few words, when pumps or dumps will induce an inflammatory cascade, there is a shift of energy toward the immune system. This will induce an higher production of nitric oxide and ROS, which will cause the cardiovascular dysfunction. But nitric oxide and ROS will induce in the cell of the peripheral organ mitochondrial dysfunction and damage. So there is a lower production of energy in this cell, and at the end, this will be the basis for organ dysfunction and organ failure. Just to give you an example, this means in the kidney that the consequence of systemic inflammation will be excessive vasoconstriction, redistribution of renal blood flow to the renal medulla, microthrombosis in peritubular capillaries, polymorphonuclear cell infiltration, apoptosis and necrosis of the tubular epithelium. In a word, this can be called immunopathology. Let me go on going back to the definition of organ failure, because we define organ failure on the basis of a Cliff-Sofa score that has been adapted to patients with chronic liver disease. What does it mean? For example, that for the definition of cerebral failure, we don't use the Glasgow scale, but we use the hepatic encephalopathy classification of New Haven. So in yellow, you can see the area that defines organ failure. So for example, kidney failure is defined by a serum creatinine equal or higher than 2.0 milligram DL. So what about the short-term mortality? You can see that a mortality rate higher than 50% at 28 days is related to the presence of 3 or more than 3 organ failure, is related to the presence of 2 organ failure, but may be related to the presence of a single kidney failure. Otherwise, you can see that the other single organ failure are not associated with a 28-day mortality higher than 50%. However, we know that a patient, for example, with a single liver failure may have some degree of renal dysfunction, may have mild to moderate hepatic encephalopathy. So if we had this concept, moderate kidney dysfunction or mild to moderate hepatic encephalopathy, to the other single organ failure, you can see that also the other single organ failure may have a 28 days mortality rate higher than 50%. So at the end of the day, we propose this classification of patients with ACLF. Grade 1, type A, patient with a single renal organ failure, Grade 1 type B, patient with a single no renal organ failure plus either a mild renal dysfunction or a mild to moderate hepatic encephalopathy. Grade 2, 2 organ failure. Grade 3, 3 or more than 3 organ failure. And you can see that there is a clear-cut relationship between the 28-day and the 90-day mortality rate and the number of organ failure. In patients with grade 3 ACLF, the 3-month mortality rate is very, very high, quite close to 80%. Now, in patients who develop acute decompensation, the further development of acute on chronic liver failure is one of the possible trajectory that can develop. This occurs in almost 1/3 of patients who develop acute decompensation, and this patient who develop ACLF has a 3-month mortality rate of 54%. The second potential trajectory is the development of unstable decompensated cirrhosis. What is it? These patients do not develop organ failure, but these patients require frequently emergent hospitalization during the following 3 months. This occurs in almost 1/3 of patients who develop acute decompensation, and you can see that the mortality rate at 3 months is around 21%. Finally, the third trajectory is the development of stable decompensated cirrhosis. What does it mean? These patients do not develop organ failure, do not require frequent hospitalization during the following 3 months. And these patients represent almost half of those who develop acute decompensation. And the mortality rate for this patient, not at 3 months, but at 1 year, is lower than 10%. So we have now this picture, but we have many problems to solve. First, we have not known predictors to define which patient with acute decompensation will then follow one among these 3 trajectories. In addition, there is a big point, what there is in the empty space of this slide. Which patient develop acute decompensation? And the question is it worthy to evaluate which patient will develop acute decompensation? I think yes. First, because, prevention is better than cure. Do you know who stated this as first? I will tell you. It was Bernardino Ramazzini, that was a professor at the Padova University in the early 18th century, during a bobbing plague in the Venetian Republic. And I take the advantage of this slide just to remind you that our university is celebrating 800 years of story, and I'm very proud to be part of this. But let me go on. Another good reason to evaluate which patient develop acute decompensation is given by the numbers. You can see that in 2017, we have almost 10 million of patients with decompensated cirrhosis and 112 million of patients with compensated cirrhosis. Much higher than in 1990, but this is related to the increase of the world population. What it is interesting to know that we were not so successful in preventing decompensation. One decompensated patient per 10 patients with compensated cirrhosis, now a value that is higher than before. In addition, in 2017, the world population was this one, you know, and if you divided the number of decompensated cirrhosis for the world population, you can realize that we are dealing with a number that is just above the threshold to define a rare disease. So I think it is worthy to evaluate what happened before. And in this perspective, we propose a new definition of decompensation in patients with cirrhosis, according to which there is not only acute decompensation that I defined before, but there is a non-acute decompensation that is defined by the progressive onset of ascites, hepatic encephalopathy, and jaundice. So there are several points that need to be clarified by the future research in this field. For example, which patient develop non-acute decompensation, which patient develop acute decompensation, how many patients develop non-acute decompensation, how many patients develop acute decompensation, which is the relationship between non-acute decompensation and acute decompensation, and which is the impact of non-acute decompensation and acute decompensation on survival. Now I will show you some preliminary data from our group that we will present at the next ILC in London. So looking to our big cohort of patients, we realized that almost 1/3 of patients develop acute decompensation moving directly from the compensated state of the liver disease. But almost one third of them develop it before non-acute decompensation. Then almost half of those who develop a non-acute decompensation then develop acute decompensation. It is important to note that non-acute decompensation has a lower impact on survival as compared to acute decompensation. And it is also interesting to note that patients who develop acute decompensation after a non-acute decompensation has the same reduced survival than those who develop acute decompensation from the early beginning. Let me go on. Try to address another question, and let me focus on the most common trajectory. So a patient who develop progressively ascites, so a form of non-acute decompensation, then will develop acute decompensation and then acute on chronic liver failure. Let me say that the probability to develop acute on chronic liver failure in a patient with ascites is 40% at 1 year, 29% at 5 years, and 41% at 10 years. The most powerful predictors in patients with ascites to develop ACLF are the following: the presence of ascites, a lower mean arterial pressure, a high MELD score, and the presence of anemia, even mild anemia. Let me focus on the first point. All the patients with ascites has a higher risk to develop ACLF as compared with those without ascites, including those with grade 1 ascites that, as I mentioned before, means ascites that is detectable only by ultrasonography. Let me move now to new achievements in the management of decompensation in patients with cirrhosis, and I will start from prevention. So the first question is, are we able to prevent the development of non-acute decompensation and acute decompensation in patients with compensated cirrhosis? The answer is yes, of course. We are able to do this by etiological treatment, and this is just an example. With the DAAs, we are able to prevent decompensation in patients with Hep-C-related cirrhosis. This is possible using this drug in patients with a childhood poor cut class A, but also in patients with the CTP class B. Probably we are not able to do this if we use these drugs in patients with CTP class C. But I want to speak about the possibility to prevent decompensation without mentioning other etiological treatments, such as the treatment of HBV-related cirrhosis, the treatment of alcohol-related cirrhosis. I want to develop this issue in an independent way from etiology. And what we have beta blockers. Beta blockers are able to prevent decompensation in patients with cirrhosis. We have a problem with the beta blockers that we cannot measure the effect, because to do this, we should measure HBPG, but nobody does it around the world. So we are giving the pill without measuring its effect. We have tried to develop some non-invasive surrogates of HBPG, but we failed, you know. For example, it has been proposed to use a combination between phosphatidylcholine and eicosanoic acid. You can see the rock curve here, but if you look at the use of this combination in clinical practice, you can see that either using a 1 cutoff or using 2 cutoff, there is a large gray zone of misclassified patients. So we have not now non-invasive markers to detect the effect of beta blockers. And so in clinical practice, when giving the pill, to look for responder or non-responder, it seems like we do a blinded fly game that is not appropriate, I think, in the era of personalized and precision medicine. What can we use else for prevention of decompensation in patients with cirrhosis? Statins. Statins have not only the possibility to reduce the level of cholesterol in blood, statins may develop several pleiotropic actions. Particularly, they are capable to reduce hepatic fibrosis, hepatic inflammation, and so at the end to reduce portal pressure. So we have some perspective data showing that statins are capable to prevent decompensation, that statins are capable to improve survival in patients with cirrhosis. But, you know, we need some controlled clinical trial. And up to now, what we have is a step forward. We have something related to the possibility to use statins not to prevent decompensation in patients with compensated cirrhosis, but trying to prevent the evolution of patients from non-acute decompensation to acute decompensation. I'm referring to the Liver Hope study that is aimed to prevent the development of acute decompensation in patients with ascites. And what we have up to now is only some achievements. The first one, we learned that we cannot use more than 20 milligrams of simvastatin per day in patients with cirrhosis and ascites. Because if we use, for example, 40 milligrams per day, the probability to develop severe rhabdomyolysis is quite high. What we learned more from our preliminary data on the liver op is the following. The combination of rifaximin and statins is capable to improve in some way the metabolism of tryptophan to where NADS, because it is capable to reduce the activity of some enzyme, I mean kynurenine aminotransferases, that may activate some collateral pathways. But let me state that the limiting step in this sequence is not the kynurenine aminotransferases, is the quinolinic acid phosphoribosol transferases, QAPRT. In fact, it has been observed that organ failure develops when there is an increased rate between quinolinic acid and tryptophan. So, for example, it has been observed that an increased rate between quinolinic acid and tryptophan is associated with acute kidney injury. But let me go on. What we have for sure to prevent acute decompensation in patients with non-acute decompensation is the long-term use of albumin. And I can state this moving from the result of the ANSWER study that we published some years ago. You know, in this study, we randomized more than 400 patients with cirrhosis and uncomplicated ascites, that means responsive grade 2 ascites, one by one to the standard medical treatment, moderate sodium restriction and diuretics, and the standard medical treatment plus long-term use of albumin, briefly 40 grams per week for 18 months. And we were able to show that the long-term use of albumin was capable to reduce the probability to develop refractory ascites. But let me say that this was in some way expected. What we could not expect at that time is the following. The long-term use of albumin was capable to prevent spontaneous bacterial peritonitis, infection other than spontaneous bacterial peritonitis, hepatic encephalopathy, I mean severe hepatic encephalopathy. That means cerebral failure, and renal impairment. That means renal failure. So the long-term use of albumin is capable to prevent in patients with ascites the development either of acute decompensation or the development of organ failure. And this is why we were able to show that the long-term use of albumin was capable to improve survival. Now, we think that in this setting, albumin is exerting not only its oncotic properties, albumin is capable to develop its several non-oncotic properties, particularly the antioxidant action and the anti-inflammatory action. Let me focus on the last one, the anti-inflammatory action. First of all, I want to show you that albumin is capable to go into the immunocell. These are leukocytes, but the same is true for the mononuclear cell. The green point that you see inside the cell is albumin. And you can see that the entry of albumin into the cell is increased by the presence of a pro-inflammatory state. Within this cell, albumin is capable to reduce the production and the release of the most powerful pro-inflammatory cytokines. So albumin is capable to exert an anti-inflammatory action. In addition, albumin is capable to prevent the damage induced by the pro-inflammatory action. So you can see albumin is capable to prevent the activation of the caspase cascade, and so is capable to prevent apoptosis induced by LPS and D-galactosamine in the hepatocytes. Why? Because albumin is capable to prevent the release of cathepsin 1b, is capable to prevent the mitochondrial damage induced by cathepsin B, and so the release of factors such as cytochrome C that are capable to activate the caspase cascade and so to induce the cell death. But you know, albumin is not a magic potion. So if we want to get some results with albumin in patients with cirrhosis and ascites, you should follow two gold rules. The first one is to give enough albumin. How much? Let me say that for the moment, the target should be to almost normalize the plasma level of albumin in your patient. If you try to reduce the amount of albumin that you will give to your patient, so if you are not able to increase as compared to placebo, the plasma concentration of albumin in your patient, you will fail. No reduction in the rate of complication, no improvement of survival. The second gold rule is to give albumin for a long period of time. You can see that the difference between these two curves, patient who will benefit from the administration of albumin, patient who will not, appears after 2-3 months of treatment with albumin. So it makes no sense, absolutely no sense, to give albumin only for 10 days, only for 14 days, only during the hospitalization. Again, no impact on any clinical outcome, particularly no impact on survival. So let me summarize what I said. Portal hypertension, systemic inflammation, oxidative stress concur in the pathogenesis of decompensation and development of organ and system dysfunction and failure in patients with cirrhosis. Two patterns of decompensation may occur: non-acute decompensation and acute decompensation. Almost half of the patients who initially develop non-acute decompensation then develop acute decompensation. Acute decompensation may evolve towards acute on chronic liver failure and has a more deep negative impact on survival than acute decompensation. Etiological treatment, beta blockers, and long-term use of albumin can prevent the development of acute decompensation. And finally, this new option should be tested to get a more effective and personalized approach in the prevention and treatment of decompensation in patients with cirrhosis. Thank you very much for your attention.
Thank you to you for the excellent presentation. I was really impressed with the amount of information and the wisdom trying to get together clinical and basic issues, making the real translational medicine. I think you should be congratulated for that.
Thank you.
I open the discussion. Please, anyone willing to have a question, please raise your hand, your electronic hand, and ask question. In the meantime, while people are thinking, let me make two comments. Number one, I'm very pleased that Ramazzini, and I remember to all the attendants of this webinar that the Ramazzini room is one of the most important rooms we have at the University of Padova. I'm coming from that university, and I'm very pleased to be an alumni of this 800 years university. It's a sort of honor for me. And two, I think that goes back to the ancient times, because if you look back in the early 90s, at the beginning of the last century, everything was related to tuberculosis, and tuberculosis means infection. So, we go back to the ancient story that most probably infection and, in my opinion, related redox state imbalance may be the trigger not only for cirrhosis but for a lot of different diseases. And I think this makes a lot of sense also in terms of the beneficial effect of albumin, because albumin, as you pointed out, is not only an oncogenic or oncogenic factor, is also related to antioxidant, and as you show very clearly, an anti-redox state. So I think this makes a lot of sense.
Thank you.
Any other question? Please don't be shy. There's no question. I mean, you have been so clear that, I mean, there's no. Let me ask another question. Do you think the statins may have a role in preventing the disarrangement or the progression of disease, also by playing a role in the reduction of the redox state? Because there are some in vitro data suggesting that statins, particularly atorvastatin, are quite good antioxidants. Do you have any clinical data on that?
I have no data on this, but you know, when we will finish the efficacy study in the liver, probably we will get a lot of information also on the mechanism of action of statins in this clinical setting. Thank you very much for this suggestion.
In the study you are conducting, you are using all just simvastatin or other?
We use only simvastatin because it is a randomized controlled clinical trial combining rifaximin and simvastatin versus placebo.
Okay, so because I think this could be. Do you have any idea when the results will be available? In almost a year?
No, we have finished the enrollment of the efficacy study. We will finish the follow-up at the November this year. So probably the paper may appear in the first month of next year.
Good. Okay, and then you are already booked to give us the answer and the results.
Thank you very much. It will be a big pleasure.
Okay, so if there's no question, I think that my due is only to thank again Paolo for his outstanding speech. It's always a pleasure meeting him and learning from him a lot of good clinical information. Thank you very much. You take care, and
I'll see you soon.
Ciao.
Ciao.
Ciao, ciao. Thank you.